Yeah, good day, guys. Hope you are doing fine. In this tutorial, I'll be talking about the descending and the ascending pathways. Okay. So from this image, you can see here is the descending pathways and here is the ascending pathways. So starting off with the descending pathways, you say that supraspinal influences on motor control are mediated through what descending pathways. Okay, that's supraspinal influences on motor pathways are mediated through the descending pathways. And also, all descending pathways are not motor pathways. E.g., we have the cerebrospinal and the retrospinal tracts that are not are not motor pathways. Now, supraspinal centers include the motor cortex and the brainstem centers. Okay. Um, Motor cortex influences spinal motor neurons via the corticospinal tracts, okay? And also our brainstem motor nuclei influence motor functions mainly via the rhodospinal, reticulospinal, and the vestibulospinal tract. Now, what are the classification of this descending tracts? Now, descending tracts you could see here, they are into pyramidal tract and the extrapyramidal tract. Alright. Now, classification of descending fibers, we have the pyramidal tract and the extrapyramidal. Now, pyramidal are descending tract that pass through the pyramid in the medulla. They are synonymous with the corticospinal tract, as the corticospinal fibers pass through the medullary pyramid. Okay. Then how about the extrapyramidal tract? They are descending pathways that do not pass through the pyramid in the medulla. Okay, these do not pass through the pyramid in the medulla. Okay, I think these are still talking about the extrapyramidal. The extrapyramidal include the reticulospinal, vestibulospinal, and the rubrospinal, and the tectospinal tract. Okay. Now we'll be talking about upper motor neuron paralysis. We say that this is the paralysis that results from the lesion of descending fibers between their origin from the cortical motor area and their termination on the anterior horn cells of the spinal cord. This is called the upper motor neuron paralysis. Now, clinically, pyramidal, that's a corticospinal tract lesion, is referred to as upper motor neuron paralysis. Okay. Now, what are the features of upper motor neuron paralysis? You see, from this image, you see where the upper motor neuron paralysis is. What are the features of the upper motor neuron paralysis? There's an increase in muscle tone, that's a spasticity. Um, there's no muscular atrophy, okay, or mild atrophy may occur in long run due to disuse of the muscle, called disuse atrophy. The muscles are usually affected in groups, okay. Tendon reflexes are exaggerated. The superficial reflexes are lost. Extensor plantar responsors are Babinski positive sign. There's non-fascicular twitches. There's no denervation potential. All right. There's a normal nerve conduction studies. Now, if only the corticospinal fibers are interrupted by the disease um, process that affects medullary pyramid paralysis or weakness of the distal muscles of the limbs and positive Babinski sign. Then how about the lower motor neuron paralysis? We say that this occurs in disease that cause the destruction of the anterior horn cells or their axons in the dorsal root, okay, nerve plexuses and the peripheral nerves. Examples of lower motor neuron paralysis disease are are nerve lesions as occur in nerve injury or diseases of the nerve. Poliomyelitis, motor neuron disease, and lesion of the nerve roots. Okay, so proceeding, we say that features of the lower motor neuron paralysis. All right, features of the lower motor neuron paralysis are actually like opposites of the upper motor neuron paralysis. And in this, we have the flaccid paralysis. Um, we have muscle atrophy, which is pronounced, and individual muscles are affected depending on the muscle supplied by that particular nerve. Um, tendon reflexes are diminished or absent. Superficial reflexes are lost. We have negative Babinski sign, and involuntary movement like fascicular twitches are observed. We have denervation potentials as fibrillation and fasciculation as seen in EMG. Um, nerve conduction is decreased or absent. Okay, so guys, this is a table showing the summary between upper motor neuron paralysis and lower motor neuron paralysis. So you could pause this video to check through. So now let's talk about patterns of paralysis. Paralysis itself means complete loss of all involuntary movement, and paralysis refers to weakness of the muscle depending on the distribution of parts of the body involved. Paralysis is further divided into two categories. We have monoplegia, which refers to weakness or paralysis of all muscles of one limb. Okay, we have what monoplegia that occurs due to disease affecting cervical segment. Monoplegia may also occur due to central uh, cortical defect, that's thrombotic or embolic infarction, or a circumscribed tumor or abscess. There's hemiplegia, which means paralysis of one half of the body. This is common form of paralysis that involves what? The arm, leg, and sometimes the face on one side of the body. It occurs due to the lesion of the corticospinal pathway at the internal capsule that results in the contralateral what? Hemiplegia. Okay, this is paraplegia, hemiplegia, one side, tetraplegia, everything paralyzed. Now, how about the paraplegia? This refers to paralysis of both limbs. It usually occurs due to spinal cord injury or disease that transect the cord. Rarely the disease of motor cortex and cauda equina or peripheral nerves cause what? Paraplegia. Then how about isolated what? Paralysis? Isolated paralysis of one or more muscles occurs due to disease of a particular nerve or a branch of the nerve. How about quadriplegia? Quadriplegia or tetraplegia indicates what? Paralysis of all four extremities. It usually occurs due to the transection of the spinal cord in the upper cervical segment. Disease of the upper motor neurons bilaterally in the cervical cord, brainstem, cerebellum can cause what? Quadriplegia. Diplegia is a special form of quadriplegia in which the legs are affected more than the arms. Triplegia occurs more often as a transitional condition in the development of partial recovery from tetraplegia. Okay, so these guys, I think we are done with our lecture on descending pathways. Okay, um, let me see something. Okay, descending pathways and the disease that affect descending pathways. So these guys, I would like to close the chapter and see us in the next tutorial. Bye for now.